I come at public health as an epidemiologist. I was a clinician first, and then public health, trained with Muir Gray and others, and then I'm an epidemiologist. And I would argue that periods of history are to some extent defined by their demography and their epidemiology. So early 20th century, we had remarkably high child mortality, growth of lung cancers, apparently unexplained, and then after the Second World War, we had this big growth of cancers, but also cardiovascular disease, which has now declined. If you look at the epidemiology now, we are in a period where we have remarkably good health in many parts of the world and in parts of the UK, and then the global burden of disease shows this brilliantly. But we also have profound inequalities. And we also have some rising threats. Martin mentioned obesity, but we also have others. And there are, there's the opioid crisis in the States. Thankfully, not as great in this country, but pretty bad in this country too. So we have a mixture of success stories and of concerns. The thing that really worries me at the moment are the deltas, and I think those are the things we need to look at. So health inequalities are actually getting worse at the moment. And that hasn't been true for most of my career. I mean, I have a copy of the original Black report. There are only 260 produced. I have a copy in my office, as well as the WHO key facts. I've also got the Lalonde report. I've got a little library. Anybody who's in Wellington House is welcome to come and look through them. There's an awful lot of commonality. So we've known this for a long time. So I'm completely with Martin. The time now is to do something, to work out what to do. And I think for all of us, it's really a personal challenge for all of us who are in positions of responsibility, and that applies to many of you I know in your roles. Are we doing everything that we could to address the problems that are now very apparent? Is there anything else that we should be doing? And if there is, then we really need to start doing it now, because these numbers are moving in the wrong direction. So that's my starting point on this. And what I'm going to do is just give you a perspective from a national public health agency, which is Public Health England. But in many of the things that we talk about are shared by other public health agencies around the world. Very briefly about health in all policies, a little bit about what we have done to date on health in all policies and health inequalities, and then more importantly tell you about a piece of work that is in train now, and many of you still have the opportunity to shape it. And so that's really the main thing I'm going to talk about. Health in all policies, you've had a brilliant introduction to this already today. From my perspective, health in all policies, it does mean different things to different people, but it needs to be systematic, and it needs to work both horizontally and vertically. So it's a way of integrating strategies and programs, and it needs to integrate across sectors, so horizontally, but it's very important that it integrates vertically between people like me who work at a national level, people like directors of public health who work more locally, but then right down to the people who are affected. And I thought Dr. Ossie made this point very well, that unless these initiatives involve meaningfully the people who are affected, they really won't work. We know that from experience and from evidence. And if you do these health and all policy approaches well, there are a few things that happen. So, three things to point out. Firstly, you tend to end up, at local level, with integration of services. You tend to also end up with approaches which are more focused on the needs and the outcomes of the people affected. And then the third thing is that you often, it's massively efficient, massively cost-saving, partly because of the other 2 points. So there is plenty of evidence out there that health in all policies doesn't necessarily require a budget. It can, in fact, generate a budget to support it. But obviously, that's another discussion that we need to have about funding of public health, which is, let's just say that's another discussion. We can talk about it clearly, it does require money, but health in all policies and the sort of things that we are talking about are highly efficient. Actually the other point is that if health in all policies is so good and so efficient, why doesn't it just happen by default? Why is it difficult? And again, we could discuss that. I think it's because it requires people with health responsibilities to give up a certain amount of authority and responsibility and sometimes budget. But at the same time, it obviously liberates and empowers others. So there's a huge win overall, but it is difficult for people with a clear health responsibility to give up the things that they're responsible for. And it does create some problems for accountability as well. So moving on then to what Public Health England is doing and has done. Well, we produced in 2016 something called Local Wellbeing, Local Growth, Adopting Health in All Policies. It was really quite an impressive piece of work. I think many of you will know about it. I hesitate to do a show of hands, partly because I can't see you, but also because I'd be horrified if nobody knew anything about it. But so what we did with this was a fairly standard, I would argue perhaps, piece of PHE work, where we started with a bit of system leadership. There are some directors of public health out there who really know how to do this. I mean, there really are some very, very impressive people. So we start with our humility of learning from our directors of public health and, of course, people who work in other areas. Very strong partnership roles with local government association and with the Associate Director of Public Health. And then we produce resources. So we try to be useful. You know, we're trying to do things which people say they want, say they use, and to improve them and develop them so that they have the most impact. And again, Martin often shows some of our products in his slides. So we know that people like you use the sort of things that we produce, and we try and make them as useful as possible. So the tool itself had had a load of these infographics. We find that infographics really do help. I mean, people take them directly from our products and use them in talking to their colleagues, so particularly trying to influence policymakers, influence local councils and so on. The infographics are very popular. And then, of course, the other thing that really helps is direct experience. So you take the tacit knowledge that you get from talking to people who've done these things, and you put it alongside practical examples which you can touch and feel, you can go and visit, and that makes quite an impressive package. So these are integrating the three forms of knowledge, you know, the research, the examples, and the tacit knowledge. And the data, of course. So that's what we produced in 2016. And on the whole, I think it has been quite popular. It's a product, and what we wanted to do, I think, in looking at what we do next, is move away from the idea of products to processes, ways of working, and really to the action itself. Fast forward a little bit to 2017 into 2018. We had a review actually within PHE of our health inequalities work, and we came to a couple of conclusions. The first conclusion was that we needed to have a more nuanced view of health inequalities as a large topic. We broke it down into three. So we have the inequalities due to socioeconomic determinants, which is in fact what I'm going to talk about for the rest of the talk. We also have inequalities due to protected characteristics, which are incredibly important, but substantially different from socioeconomic inequalities. And it's a mistake to try and, if you conflate them in policy and intervention terms. So it's important to make that distinction. And then the third group are the inequalities due to various inclusion health problems. So it's one thing living in an area that's deprived. It's another thing living in an area that's deprived and being a drug user or being an offender or being a sex worker or being a recent migrant. So, and again, the approaches that you use for the first two categories of socioeconomic deprivation and inclusion and protected characteristics don't work for policies that are aimed at addressing the problems of inclusion health. So we now have three different approaches. In fact, in three different parts of our in PHE, we have different people leading on them. Obviously, they're interrelated, but they are different. And I'm particularly pleased that we've moved migrant health from health protection into health improvement. So migrant health used to be all about hepatitis and HIV, and now it's integrated with what we do around drug users and others. So that was one thing we did. The second thing we did was to look at our role as Public Health England, and we wanted to concentrate on two areas, one on working with other government departments at the policy level, and the second was in supporting local action. So very much the sort of things that you've heard about now from Martin. And on the other government departments work, again, that's a whole nother talk, but just as an example, we worked a lot with DEFRA, Department for Environment, Food and Rural Affairs, in the development of the 25-year Environment Plan. And in fact, Chapter 3 of that plan is pretty much scripted by many of my colleagues. And if you want to know more about it, Karl Petrakowski is in the audience, so he can tell you more about it. But I mean, there are huge areas of opportunity for us to work at government level with other government departments. Of course, what we really want to do is to get involved with the welfare agenda and working with DWP and Treasury. That's much more difficult. So, on to supporting the local system. And I should say here that this joint strategic framework, we're calling it, it's a working title, it doesn't really tell you very much, it could be almost anything with that title. We're still developing it, and it isn't launched yet. So I'll just give you a flavour of what's in it, and hopefully you will see it in the summer, and some of you may even get involved in developing it. The idea is to provide a bit of structure and vision for people working at local level on place-based action that is really going to make a difference to health inequalities, using very much a health in all policies approach. And we're working together with Local Government Association and ADPHs. Of course, we're building on what's been done before. We're trying to take it to the next level. We're trying to make it more about process and action and less about producing products, although, of course, there will be some products. And it's intended pretty broadly for those people who are going to really make a difference at local level, and we're going to draw it very broadly. Increasingly, of course, that means now the NHS as well. So I think with the long-term plan, there's increased interest in how we can get the NHS involved. And then finally, in terms of format, we're going to make it more of a live, modular, developmental sort of digital output, which I think is, the evidence is that is what people need, and it does work, and it is more helpful. I mean, very briefly, how have we done it? Well, we started with, I think, considerable humility. We've gone out and talked to people. We've done interviews, people in the local system, various, not just the senior people working on the ground. We've done focus groups, we've engaged with organisations, and we're in the process now of testing it. So we're looking for some local authorities to help us test the nascent framework. And then I think, and we're going to publish it in the summer. So what's in it? Well, it's sort of what you'd expect, I expect. There's something about the current context, so help people to understand where we are, some key facts, and some content from other countries as well. A bit about the causes, and I'll mention the model about causes there, which I think is still important to stress this. And then, of course, where the rubber hits the road, sort of place-based guidance for action on health inequalities, and that's really the nub of what we're trying to produce. And the form, we'll produce a framework, and it'll have with it various infographics, summary slide sets, a self-assessment guide, very much a sort of sector-led improvement type approach, which many of you will recognise, case studies, and plenty of data. So that's where we are at the moment in terms of what we're thinking about what's in it. I mentioned the models again. We're building on what's out there already. The Labont model of what causes inequalities is very widely used, quite widely understood. It's very powerful, particularly if you think from our colleagues coming into this, maybe clinicians coming from an NHS more of a biomedical model. They're approaching here at the, it's obviously important to find and treat high blood pressure, get people's cholesterol normalised, and to manage their mental health. I thought a brilliant presentation before about joined up mental health services. That's fantastic. Of course, you need to address behaviours. We need to have people more physically active. But if you don't address the psychosocial problems of isolation and poor networks, and if you don't address the wider determinants of health, then this bit at the top really isn't going to work. And that's basically the model. And then wonderful tribute to my friend and colleague Chris Bentley, who developed this this triangular approach to how you work locally. You need to integrate things, civic level interventions, so things like improving transport and housing and a lot of the things that councils are responsible for. Service-based interventions delivered by a whole range of different people, not just the health service, but clearly voluntary sector as well. And then community-based interventions, the sort of assets that are out there, faith groups and a whole load of other things, men in sheds and all kinds of things that really, as we know, make a difference. So that's it. It's not, I mean, these will be familiar, but nevertheless, bringing it all together, I think is quite powerful. So this is just a summary of where we are. We're in the process of testing it. We're really keen to avoid producing something that people either don't want or is the wrong thing or is in the wrong format. And if when we test it people say, we don't need this, we know all this already, then we just won't produce it. But I'm hoping that people like you will find it useful. And at least if you don't like what we produced first time round, you'll help us improve it and make it something that is useful. And of course we need to evaluate it and share it and generally get it out there. So there we are. Thank you very much.